Good evening, everybody. Welcome to the second module of our Head and Neck Weekly webinar series. As you know, we've been having a bi-weekly sessions. We've finished the module on the neck, and we've had some eminent speakers join us for that. And this is the second talk that we're going to have in the oral module. And we're very happy that we've had such exemplary speakers join us from all over the world. In fact, today's is a very special session. We look forward to this with a lot of eagerness because we have Dr. Shaha, who's joining us all the way from New York, even though it is early hours. Thank you, sir, for joining us.
My pleasure.
Thank you, sir. So just to tell you a little bit about what we are doing, we've been having these webinar series, these weekly webinar series for about a month now. We've been trying to make as much use of this COVID times as we can. And so with the help of my senior colleagues, Dr. Vishal Rao, Dr. Ravi Nair, Dr. Akshay Kurpaje, we've been able to launch this. Also, we have launched the COMED series parallelly, which is the continuing medical education series. And we've begun with the minimally invasive head and neck surgery modules, which is now focusing on the transoral laser surgeries. So we've had one session on it last week in which international speakers from all over the world joined us. And now tomorrow, the 5th of July, we have another session. So this is going to be a 3-hour long session. Please make sure that you join us for this. To focus now on today's session, we'll be speaking about so this is, like I said, it is the second module on the webinar series. We've had a whole bunch of people who are doing great work in their field join us, and today we are going to be talking about the new AJCC guidelines for oral cancer, and who better to speak about it than Dr. Shaha himself. To moderate today's, our speaker for today is Dr. Abhishek Vaidya, and to introduce him, I would like to introduce today's moderator, Dr. Shakti Singh Deora. Dr. Shakti Singh Deora is a head and neck surgeon who is practicing in Ahmedabad currently. He's been trained in head and neck surgery as well as in reconstructive surgery at Munich, Germany, and Taiwan as well. He is also trained briefly at MSKCC and also holds the IFNOS Golf Fellowship. He has been very helpful to me, and he has guided me on a lot of occasions. So welcome, Dr. Shakti Singh, sir. I hand over the session to you now to take it forward.
Thank you, Shalini. So there are major challenges in clinical implications of 8th edition of AJCC TNM classification of oral cancer, and especially countries like us where the oral cancer is a rampant disease. So we are here to discuss the challenges, limitations, clinical implications of TNM classification for oral cancer. So let's get insight on this from our experts. Here we have Dr. Ashok R. Shah as our invited guest speaker from Memorial Sloan Kettering Cancer Center, New York. Dr. Shah needs no introduction. He is a very well-renowned, eminent head and neck cancer surgeon with a vast amount of knowledge and experience. Although for a short duration, but I have been fortunate to learn from him from MSKCC few years back. And I tell you that he is not only a fantastic surgeon, but an excellent human with a great sense of humor. We thank you, sir, for joining us on this morning. We have next our speaker, Dr. Abhishek Vaidya from India. Dr. Vaidya is a senior consultant in head and neck oncology at National Cancer Institute, Nagpur. Dr. Vaidya completed Masters in Otolaryngology. Thereafter, he has been trained at Tata Memorial Cancer Center and he has worked with Niti Clinics, Nagpur. Dr. Vaidya is a international fellowship, global online fellowship from MSKCC and IFNOS. So now I hand over to Dr. Abhishek Vaidya to continue forward.
Thank you very much. At the outset, let me thank the Academy of Head and Neck Oncology of Karnataka, HCG Academics, Dr. Vishal Ravi, and the entire team. I'm truly honored to have Professor Ashok Shah moderate this talk. I've been told that we are going to have a mixed audience for this talk, so I'm trying to keep it basic, include the changes in the AJCC 8, and then try and identify the pros and cons of it. So without further ado, I start my talk today. So to begin with, we know that the AJCC is a very well accepted, globally accepted cancer staging system. AJCC itself works in close association with UICC, and their classification systems are almost identical. The first classification system was brought out in 1977. Work for the 8th classification system began in around 2015, publication in 2016, and it's effective from 1st January 2018. So for the authors of the AJCC, the vision this time was to not just bring about population-based survival outcomes, but also to bring about personalized survival outcomes. And this is reflected in the philosophy that they've approached. They've included the routine TNM staging, added factors, and also risk assessment models, along with stratification for clinical trials. Before we move on to the AJCC itself, let us understand what are the key principles of any staging system. Any staging system should effectively result in 4 criteria or 4 outcomes. The first is hazard consistency, by which I mean that cancers which are grouped together in one group should have a similar survival within that subgroup. Second should be hazard discrimination, which is the opposite of the previous, that cancers which are grouped into different groups should have different survivals. There should be group balance, that there should be a relatively equal number of subjects in different groups, and this should mirror the incidence and prevalence of those cancers in the community. And finally, they should have a high predictive ability so as to give a good prognostic criteria. So with that, let us first understand the basic changes in head and neck cancer staging which were brought about in AJCC 8. So we begin with the most prominent change, and though my brief for this talk does not include oropharyngeal cancers, I'm going to speak about it nevertheless because it's an important topic coming forth in AJCC 8. So entirely new staging paradigm for HPV-associated oropharyngeal cancers has been proposed this time. There is an updated T staging for oral cavity, nasopharynx, as well as cutaneous squamous cell carcinoma and basal cell carcinomas. There is an expanded nodal staging, N staging, which now includes extranodal extension or ENE. Staging for the pharynx has been restaged to include 3 subgroups. And finally, there have been changes in the nomenclature for unknown primary within the staging system. But for this talk, we are going to talk about the 3 outlined things here. HPV-associated oropharyngeal cancers, the new T staging for oral cavity, and of course, the expanded staging for nodal disease, which includes perinodal extension. Let's begin with oral cancer changes. So the most important change in AJCC 8 this time around has been the inclusion of depth of invasion. AJCC now acknowledges that small oral cancers which are deeply invasive have a different behavior, or rather than the largest dimension, it is the depth of importance which carries greater prognosis. So the depth of infiltration has now been included, and this is based upon convincing data from previous studies that this is a better predictive parameter for invasiveness rather than the tumor thickness. What is the difference between the depth of invasion and tumor thickness? I'll come to that in a minute or two. The definitions and methods for measuring depth of invasion have been specified in AJCC 8, and it is recommended that a combination of careful palpation and imaging be used for clinical examination, whereas for pathology, of course, it's a microscopic measurement. So let us understand what is depth of invasion. I hope my pointer is seen here. So the depth of invasion is how much the tumor actually invades into the tissue, and not the thickness of the tumor, which would account for the maximum dimension of that tumor. So for measuring the depth of invasion, you have to identify the basement membrane of the adjoining normal mucosa, which is seen here as I'm showing it out on a pointer, and draw horizontal from this. The next point is to draw a perpendicular or a plumb line from this until the maximum extent of the tumor. So the height of a plumb line or a perpendicular drop from the level of the normal mucosa is the depth of invasion. And this the part of the tumor which is above the basement membrane also, along with the depth of invasion, together constitute the thickness of the tumor. And that is better understood in something like this. Here, the white line indicates the thickness of the tumor. All right. Whereas the perpendicular or the plumb line from the level of the normal basement mucosa indicates the depth of invasion. So it is the depth of the invasion which has to be measured and reported, and is to be included in the T-stage classification. So this is the new T-stage classification according to the depth of invasion. TX and TIS are similar to previous classifications. T1 now includes tumor which are less than or equal to 2 centimeters in size, less than or equal to 5 millimeters in depth. And T2 includes tumors which are less than or equal to 2 centimeters in size in a maximum dimension, but the depth of invasion is between 5 to 10 millimeters. And it also includes the previous T2, which is tumors which were between 2 to 4 centimeters in size, but once again, which were less than 10 millimeters in depth. Any tumor which is more than 4 centimeters or has a depth of more than 10 mm is included in T3. T4A and T4B are more or less unchanged. So the take home is, for every 5 mm increase in the depth of invasion, both the clinical T size and the pathological T criteria would increase by 1 level. I said T4A and T4B are more or less similar, but one of the things which has been omitted is that extrinsic muscle involvement is no longer an indicator of T4A. The next point is concept of perinodal extension or extranodal extension. We know from several studies that extranodal extension is one of the most important prognostic variables for head and neck squamous cell carcinomas. Two meta-analyses recently have identified E&E as one of the most important prognostic factors. When we look at studies such as Burney and Cooper, which studied adjuvant chemoradiotherapy for oral cancers, they once again included extranodal extension. So it was about time that this had to be included in the TNM classification. We know that E&E profoundly affects prognosis for all head and neck cancers, with the possible probable exception of T16 positive. And therefore, TNM now includes E&E. However, to minimize stage migration, the bar of inclusion for TNE for E&E has been set relatively high. And these are the definitions of E&E. For clinical extranodal extension, there should be invasion of the skin or infiltration of the musculature or dense tethering to the adjacent structures, or a cranial nerve which is dysfunctioning, or a brachial plexus or any other nerve trunk which is dysfunctioning. So the clinical criteria have been set very high so that there is no easy clinical stage migration based upon E&E. And for pathology, E&E is divided into minor E&E and major E&E. Minor E&E is extension of the tumor beyond the capsule but less than 2 millimeters, and major E&E is extension of the tumor beyond the nodal capsule more than 2 millimeters, or something which can be examined by the pathologist on gross examination alone. So this is the revised N criteria, and I want you all to focus only on the one which I have highlighted in the red. N2A is now metastasis in a single node, which is less than 3 centimeters in size, but E&E positive. N3B is metastasis in a single ipsilateral node, which is more than 3 centimeters in size, and E&E positive. So N3B is a new stage which has been added, and N3B is the highest stage in the nodal classification. And this is any node which is more than 3 centimeters and has extranodal extension. On the other hand, any node, single node, which has perinodal extension but is less than 3 centimeters in size, is now included in N2A and not in N1 as was previously done. Right. So for any changes in the classification system, they are only tested when they are correlated with the real world data, and this really is the proof of the pudding. The validation is the proof of the pudding. And the AJCC T stage, immediately at the time of the publication, they were validated using an MSKCC and Princess Margaret Hospital data of oral cancers. And this is the AJCC 8T classification, and you can see that there is an excellent stage separation, which validates the criteria which were used for AJCC 8. This has also been evaluated in several retrospective studies, and I'm only putting forth the largest study. This is a Brazilian study which compared the performance of AJCC 8 as compared to AJCC 7. This panel is slightly busy, but on the right-hand side is AJCC 8, and on the left-hand side is AJCC 7. The top two panels speak about disease-free survival, and the bottom two panels speak about overall survival. And this is vis-a-vis T-stage in AJCC 7 versus AJCC 8. Now, if I may divert your attention to the bottom of the slide, the patients which were upstaged by AJCC 8 had statistically significant worse DFS and OS when reclassified according to AJCC 8. And similar validation for the AJCC end staging has also been done. This is one of the MSKCC PMH data. And once again, I'm putting that slide from the Brazilian study. This is once again for end staging. The panels on left are ACL and right AJCC 8. The two panels on the top are disease-free survival. The two panels on the bottom are overall survival. And once again, may I divert you to the bottom of the screen that both disease-free survival and overall survival in patients who were upstage using AJCC 8 was statistically more significant, once again validating AJCC for both the T and N staging. Mind you that these studies are for oral cancers only. We now quickly move on to oropharyngeal cancers. What necessitated this aging? We know that the incidence of oral cancers due to HPV is growing, especially in the West. These are demographically different, and they're also prognostically different, and they also have difference in response to treatment and prognosis. So basically, oropharyngeal cancers can now be divided into two broad groups. One of them are HPV negative and have other correlates such as keratinizing, elderly males, history of smoking, usually P53 positive, and often more aggressive. The other group, of course, is HPV positive, and which are associated with a completely different set of correlates. Younger men, non-keratinizing, usually no risk factors such as smoking or drinking, P53 negative, and improved prognosis. However, the previous AJCCs did not include these two as different groups. And what happened was there was skewing of the stages. So if I may take you back to the original slide, we said that there has to be hazard discrimination and predictive ability. For oropharynx, both of these were being lost by not including HPV positive versus HPV negative. There was loss of hazard discrimination as well as loss of predictive ability. The new staging for HPV positive, the new staging for oropharynx according to AJCC 8 now includes HPV positive as well as HPV negative, and both of them have been staged differently. Let's look at the staging for HPV positive. The differentiating test the AJCC realized had to be simple, inexpensive, and reproducible. So HPV DNA was not the test which they proposed. Instead, they proposed HPV16. P16 on immunohistochemistry. P16 we know is a robust biomarker and is a very good prognosticator by itself, and it correlates very well with HPV DNA with fish. So oropharyngeal cancers are now staged according to two distinct systems, whether they express P16 or whether they do not express P16. So for HPV positive cancers, the overview is as follows. T classification is largely unchanged except that T4B is removed. And in N classification, there's a difference between the clinical and the pathological stagings. Clinical staging now is based upon laterality and the size of the nodes, and the pathological staging based on the number of nodes. And this is obviously for patients who are treated with surgery. Perinodal extension is not included in the AJCC N classification for HPV positive, and this may probably be a critique of this, and which we'll come to in a couple of minutes later. M classification obviously is unchanged. So for HPV positive cancers, it's essentially the same except that there is no T4B because there were no hazard discrimination between T4A and T4B curves. So for HPV, the slide should read HPV negative. HPV negative oropharyngeal cancers, it's more or less the same. For end staging, and this is for HPV positive cancers, N1 is now ipsilateral lymph nodes less than 6 centimeters in size, regardless of the number, and they are all now classified as N1. N2 is bilateral or contralateral lymph nodes less than 6 centimeters, regardless of the number. N3 is any node which is more than 6 centimeters in size. So this is a big change in the end staging for HPV positive oropharyngeal cancers. So this is the simplified clinical staging. N1 is one or more ipsilateral nodes, none larger than 6 centimeters. N2 is contralateral or bilateral nodes, none larger than 6 centimeters. And N3 is any node more than 6 centimeters. So N2A and N2B, N2C have been removed from this. Once again, ENE is not included, and this is probably a critique of the system. Am I good on time, or should I move on to the critique?
So you have more than enough time, you can go.
Okay. So the pathological end staging, obviously this is applicable only to patients who undergo surgery, but the data is slightly different here. On pathology, it was found that neither the lymph nodes size, that is less than or more than 6 centimeters, nor contralateral nodes impacted survival, unlike for patients which were treated with radiotherapy. The number of pathological positive nodes yielded survival differences. So for N1 and N2, it was 1 to 4 and more than 4. N1 is up to 4 nodes and 5 or more nodes are N2. So that's again a slight change for pathological staging for HPV positive oropharyngeal cancers. So there are quite a few changes in the end staging for oropharyngeal cancers in AJCC8, which are HPV positive. ENE is not included. And for HPV, which are treated by surgery and therefore P staging is available, note that there is no P and PN3. Because once again, there was no significant survival difference or hazard separation between N3 and N2 of the previous systems. That is the overall staging. Note especially that stage 4 is reserved for any M1 disease. And stage 3 is reserved only for bulky tumors. So most of the tumors would now fall into stages 1 and 2. P staging for HPV negative oropharyngeal cancers is more or less the same, except that T0 is removed. End staging for HPV negative oropharyngeal cancers is the same as I said before. It now includes perinodal extension in N2A and N3B. Overall, for HPV negative oropharyngeal cancers, the staging remains more or less unchanged, and this is a vast difference from that for HPV positive cancers, where 3 was only for bulky disease with multiple nodes, and 4 was only received for metastatic disease, whereas 4A, 4B, and 4C is there for HPV negative oropharyngeal cancers as previously. So before I move on to the advantages on the critique, there is an important concept which I want you to look at. This is stage migration. Whenever a new classification system comes into being, some of the cancers which were lower stage will be moved to a higher stage. And Will Rogers, who was a comic, once famously used this sentence, and he said that when the Okies left Oklahoma and moved to California, they raised the average intelligence level in both the states. That was quite stinging, but the implication in oncology is that whenever a new staging system comes into being, those patients with the worst cancers are now moved to more advanced stage, and therefore the early stage cancers artificially tend to have better outcomes. As that happened with AJCC8, more validations of AJCC8 would be required, and this remains to be seen. We now move on to the pros and cons, or the leaps and gaps of this classification system. AJCC8, it recognizes the need to categorize the prognosis of similarly sized tumors, but with much different clinical and biological behavior. And especially we are talking with respect to the depth of infiltration and the HPV status for oropharyngeal cancers. It now incorporates etiological and molecular factors and established pathological prognostic factors such as perinodal extension, which is a very welcome move, as well as depth of infiltration. However, it is not without fallacies, and there are certain points to critique. The biggest bone of contention has been the depth of infiltration measurement technically. Now, one would expect that imaging would provide a reasonable estimate of the depth of infiltration measurement preoperatively, but it's the clinical examination assessment of the depth of infiltration which is not uniform. Tumors in the oral cavity are painful. There might be trismus, and at the very worst, you might only be able to give a very a very rough approximation of the depth of infiltration. So this is an important fallacy of the AJCC8, and this is something which needs to be addressed. The second point is the proportion of HPV positive patients, especially in developing countries, are not known. So P16 as a part of the staging procedure for all oropharyngeal cancers may not be a prudent policy. Also, with respect to oropharyngeal cancers, the pathological or the molecular staging is very well done in AJCC8, but the anatomical staging is something which can be improved upon, and this is especially with respect to pharyngeal constrictor muscles, because this is what is taken into consideration when robotic surgery for oropharyngeal cancers is being planned. So anatomical staging, taking into consideration the local anatomical musculature, is something which would be much welcome in further iterations of AJCC. We know that involvement of extrinsic muscles may have been omitted in AJCC8, but this is something which probably may have a prognostic role, and therefore this is something which needs to be relooked at. Finally, regarding clinical assessment of extranodal extension, the bar has been set very high so as not to easily define C in 3B, but this is something which needs to be better defined to identify unresectability based upon clinical criteria. Further, we know that there is a low intra-observer as well as inter-observer agreement when perinodal extension or extracapsular spread is assessed on imaging. And there also is a lack of consensus regarding the imaging criteria for perinodal extension in case of nodes. But to summarize, AJCC8 has made very remarkable and drastic changes in head and neck cancer classification. It now attempts to strike a right balance between acceptable, user-friendly, popular approach, which was what was previously done, and more complex, personalized approach. The future, of course, lies in individualized mammograms and even a personalized approach. Thank you for your attention.
Thank you, Dr. Abhishek. It was a very informative session. And now I invite Dr. Ashok Shah, sir, to please enlighten us further about the classification, sir.
Thank you very much, Shakti. I enjoyed the presentation by Abhishek. I think he summarized it very well. The last couple of slides were very important in his presentation. And those are some of the limitations of staging system. You got to understand the basic idea behind the staging system, whether it is a head and neck tumors, pancreatic tumors, stomach cancer, anywhere, is to identify the same sets of patients around the world. So we have a clear idea who does well and who does not do well. If you look at the staging system in the head and neck, this is the 8th edition. Means it is an evolving process. The 9th edition may have major changes. Now there is a major difference between 7th and 8th edition, partly because of understanding of the prognostic factors. And as we learn more prognostic factors, there will be more changes in the staging system. Generally, it takes about 4 to 5 years to change the staging system. If you change it every year, people are not going to remember that. They're not going to use it. If you change it at let's say 10 years, people are going to also forget about the previous staging system. Another important point in the staging system is the AJCC, UICC have tried to centralize the staging system so that we have got a uniformity in staging around the world. In spite of that, there are many areas where people use different staging system. And the classical example is nasopharyngeal cancer. If you look at the nasopharyngeal cancer in Southeast Asia, where the disease is extremely prevalent, the staging system is much different. Obviously, they are trying to abide by the staging system which has been popularized by AJCC. But it takes time because they have full belief in understanding their own prognostic factors. So the most important understanding the staging system is the evolution of prognostic factors. As we collect the data more, we identify more prognostic factors and we try to integrate those in the staging system. If you look at the staging system in the whole human body, the classical example is melanoma. At one time, the melanoma staging system was very simple. It became more complicated and more complicated because the randomized prospective studies and the other studies in melanoma, which are worldwide, identify a variety of prognostic factors. And the consensus was those should be included in the staging system to identify proper stages. Unfortunately, the staging system became quite complicated. If you look at the melanoma staging system, you can't remember it. You have to carry a small book or a paper to understand exactly what is the staging system. Now, that has some implication on this. The more complex staging system you make, the less it is adopted. You know, there is a KISS principle. Keep it simple, stupid. If you keep it that way, people will remember that and use it. The more complex you make it, the more difficult it is for people around the world to understand and employ in their day-to-day practice. There is another major impact. The major studies or the major data collection by SEER, which is an American group, and the NCDB, National Cancer Database, the information is entered by registrars. These are the trained people. They know how to stage the patient. They look at the chart, which is obviously retrospective, and they enter the information which we use to analyze the data critically. Now, if the staging system is complex, it is very difficult for the registrars to enter that system properly. And then the data that comes out, or we analyze the data, is probably not most accurate. So keep in mind the limitations of the staging system. This time in 2018, when the 8th edition came out, the major impact was because of oropharyngeal cancer, which has become probably the most prevalent head and neck cancer in United States, HPV-related disease. And it has become very common. We also learned in the earlier years that this is the most sensitive to all forms of treatment. Obviously, there is a debate whether you want to do surgery, you want to use radiation therapy alone, or a combination of radiation and chemotherapy, or in rare instances, all the three modalities. Again, we need to put that in proper perspective, that oropharyngeal disease is a different disease. It used to be like what we used to call nasopharyngeal cancer, lymphoepithelioma, or tonsillar cancer, almost the same. This is a different disease. Naturally, because it is different and the outcome is different, the staging system is also different for that disease. And even though the staging system is modernized, I think it is still quite complex. If you look at the end staging system, the number of lymph nodes, 6, more than 6, one side, both sides, it's not going to be easy for everyday person to understand it and employ it. So the few points I want to bring up, staging system is an evolving process. The reason we use AJCC, UICC is it has adjusted to all the prognostic factors which we understand and which can be employed in clinical practice. The next point is there is a difference between clinical staging and pathological staging. The depth of invasion, which Abhishek described well, is very easy in the final pathology report. It is difficult in clinical practice. Now, it is said you can feel the tumor on the tongue and give the depth of invasion, but that's not going to be same as somebody else examining the patient. So prognostic factors are very critical. Understanding of the biology of the disease is very important. And the 8th staging system, whether it is a head and neck or thyroid, has adhered to all these prognostic factors. The other important aspect is understanding of the evidence base. the reason there are major changes in the 8th staging system is these are probably the most evidence-based staging systems. And the more we learn about the prognostic factors, the more changes we're going to bring. I'm sure the 9th and 10th edition are going to be state of the art. Some of the important aspects which are being discussed right now, which are not included in the staging system, number one is the molecular markers. I think those are going to be important in future. The problem is there is no uniformity in molecular markers, number one. Number two, every pathology department and every institution does not use it. And number three, the numbers are so small in the publication. Let's say you take tongue cancer and a molecular marker. The numbers are so small from a given institution that you cannot use it all around the world. I use one marker, you use different marker. So we're going to have a diversity of opinion. But eventually, I'm very confident that we'll be able to add the molecular markers. And that has been used in prostate cancer, not in the staging, but in the prognosis and treatment of prostate cancer. And as I mentioned, the evidence-based depth of invasion we talked about, the one other point I want to bring up is the comorbidities. I think there is a lot of discussion about use of comorbidities in the staging system. The problem is it's very difficult to standardize the comorbidities. I may look at the comorbidities in one aspect. The patients in the United States may be different than patients in Southeast Asia or in the third world countries. So there is no uniformity of comorbidities. But if you look at the prognostic factors, one of the most critical prognostic factors in the outcome, in the complications, long-term survival, and is the comorbidity aspects. And those will be included in future in the staging system. And the last point before I stop my comments is the nodal burden. There's a lot of interest now in the nodal burden. And just to make it very simple for you to understand, what is nodal burden? You do a neck dissection. How many lymph nodes did you remove? Let's say you have removed 50 lymph nodes and 5 are positive. That means the ratio is about 10%. That's the best patient. You're going to get the best outcome. Let's say you have removed 20 lymph nodes and 12 are positive. That's a 60%. That's not good. So we're going to have the understanding of the nodal burden and the nodal ratio, which is the ratio between the number of lymph nodes removed and number of positive lymph nodes. This is very important in cancer of the oral cavity. It is quite important in other oral cavity cancers, especially the tongue cancer, which is very prevalent. I'm not sure it will be of great value in the oropharyngeal cancer or hypopharyngeal cancer. Definitely, it has very little value in nasopharyngeal cancer because those are the diseases where we don't do neck dissection. But in thyroid cancer and other human cancers, I think the nodal burden is of great importance. So again, I just want to summarize that staging system is an evolving process. As we learn more about the prognostic factors, we're going to see more revisions in the staging system. Is including the pathology, the radiology, radiation oncology, medical oncology, and they spend enormous amount of time. You know, we look at the 4-year product of a new staging system, but if you really understand how much time and effort has gone behind it, it's mind-boggling. More than 25 to 30 investigators have put together their minds, their data, and analyzed the data more critically, and try to analyze only the data which has some important clinical parameters. And then the staging system comes up. So I just want to summarize that this is an evolving process. as we learn more and more about the prognostic factors, we'll see more evolutions. The comorbidities, the molecular markers, and nodal burden is something that we will learn more in the next staging systems. Thank you very much.
Thank you, Dr. Ashok Shah sir, for such a crisp and concrete information on the TNM revision staging. Now, I think we would like to take few questions from the audience. So, my first question, I will direct it to Dr. Ashok Shah sir regarding the subsite variations within the oral cavity. Does it influences the staging and the prognosis?
At present, according to the staging system, no. But if you ask my personal opinion, the tumor of the lip is much different than tongue cancer.
Exactly.
And the classical example I always use in all my talks is tongue cancer is a different disease in the oral cavity. If you look at the risk of nodal metastasis for T1 tongue cancer, it's about 25 to 30%. For T2, it is 50%, and for T3, it is 70%. So when we integrate the decision making, tongue cancer is a different disease. When the tongue cancer extends onto the base of the tongue, it is much more different compared to the buccal mucosa cancer or gingivobuccal sulcus cancer, which brings up the issue about the closeness to the mandible or the maxilla. So every individual site is going to have different decision making. The problem is, you have to, as I said, it is an evolving process. We can't make it very complex and difficult. If you have got the different staging system for lip cancer, oral tongue cancer, the buccal mucosa, people will never use it. They won't report it on their databases. So we won't have any uniformity. So yes, I completely agree. The different locations have different outcomes, but we use a generic staging system. Again, the important aspect is to understand stage 1 and 2 are early, stage 3 and 4 are advanced. And I'm going to add one more thing. The decision making in the early stage cancer is preferably single modality treatment, while in advanced, where the outcome is low or poor, you use multimodality. That's the nutshell of the locations.
Thank you, sir. Now, the next question, I will direct it to Dr. Abhishek regarding what will be the TNM staging of a tongue lesion, which is around 4.5 centimeter and a depth of 1.2 centimeter with no bony erosion. So, Dr. Abhishek, did you get my question? Dr. Abhishek, can you hear me?
He might have muted.
Yeah. I can hear you. I just muted it. Right. So the question is, what is a T? I can read it here in the chat. What is a T staging for a tumor size of 4.5 centimeters and depth of 1.2 centimeters?
Yeah, correct.
So you can see this is something which is criteria crossing both the criterion for depth as well as size. 1 centimeter of depth and 4 centimeters of maximum tumor dimension. So if we go back to our T staging, this is a tumor more than 4 centimeter or more than 10 mm DOI. So this is T3. For tongue, the previous AJCC included extrinsic muscle involvement, which of course has been removed now. And since there is no bone invasion, this will remain T3.
Okay, thank you. So my next question is for Dr. Ashok Shah, sir. Which is the best imaging modality for clinico-pathological correlation, sir?
What is available with you? I'm going to make it very simple. Clearly, as a surgeon or as a clinician, CT scan is of great help. And there are many reasons behind the CT scan. See, if you look at the imaging systems, you include 4, the most common. One is the ultrasound. Most of the surgeons don't understand how to interpret the ultrasound. If you look at the oral cavity, it's very difficult to get the depth of invasion with the ultrasound. It can be done, but it is very difficult. The ultrasound for the neck is very good. It was very popular in Europe. Even there, they don't use it routinely now because it is a operator dependent. So that is number one. Number two is a CT scan, which I like very much because I can interpret it much better. It is not of great help for the superficial tongue cancer because you can't appreciate anything. But it will be very helpful to know that there is no deep-seated tumor, number one. There is no crossing of the tumor to the midline, number two. There is no extension onto the mandible, number three. And more importantly, we can evaluate the lymph nodes better with a CT scan. The next investigation is MRI. And I must admit, I find it very difficult to interpret. I have to go to the radiologist and get his or her opinion to interpret the MRI. The PET scan, I can make it very simple. We rarely use it in the initial imaging unless the tumor is T17, stage 17, where we want to get the information about the distant disease. And the last point I want to bring up is when you talk about the imaging, what is the best imaging for mandible? When the tumor is in the floor of the mouth, what is the best imaging for mandible? And again, we have gone through evolution of this imaging. Again, to me, the CT scan, the cross-sectional imaging with the CT scan is very helpful. Some people will use a panoramic X-ray, which is not of great help, DentaScan and many other scans, but a well-done CT scan will give you better information about the cortical erosion, either inside or outside the mandible.
Thank you, sir. Now, next question, I'll direct it to Dr. Abhishek regarding, okay. Any comments on staging on metastasis of unknown origin incorporating tissues of original studies? So there has been questions sent to us.
That is an interesting question. When I was in training, you do a biopsy of the lymph node, and one of the pathologists would tell us, without knowing any history, this is from tonsil, or this is from base of the tongue. He was smart. He knew because of his vast experience. Andy he passed away about 10 years back, but he could tell the origin. Again, if you have a lesion, which is like a lymphoepitheliomatous lesion, or now the oropharyngeal tumors, you can make a diagnosis that this is probably from the oropharynx, looking at the metastatic disease in the neck. Obviously, the HPV positivity P16 will definitely direct you to understand that the primary is probably in the oropharynx. Now, you have to realize the 8th staging system put unknown primary as a special category. We did not have that before. We lumped them together with the head and neck cancers. And the reason behind this is, it is probably a different disease now. Majority of the unknown primaries, we can find the primary, which is in the oropharynx. But a small minority, about 5%, will never know where it is coming from. And that's where the staging system comes up and the differences in philosophy of management comes up.
Yeah, okay. Thank you, sir. Dr. Abhishek, I would like to ask one thing. Is there any staging for proliferative tumors? I think you are muted, Abhishek.
Yeah. Sorry about that again. Yeah. So I think the question is whether tumors which are more proliferative than infiltrative, would they have a different staging system? No. Yeah. In that case, the maximum tumor dimension would be used to calculate their T stage up to 3, or their involvement of contiguous structures would then determine T4A. So with respect to whether it's proliferative or infiltrative, there is no different stages.
Okay. So Ashok sir, there's one question. You just said stage 17, so I think they wanted to know the tumor.
When you work in the areas where the average presentation is more than T4, stage 4, we call it stage 17.
Just
there is a term we use in New York, a big Goomba. G-U-M-B-A. They are all stage 17 cancer. It is a vernacular slang that these patients present with advanced disease.
Okay, great, sir. So one more question. So, like the potentially malignant lesions that have high propensity to have malignant transformation, can they be stage 0?
That's, I don't think so. Because the whole staging system preamble is that it should be cancer. We stage leukoplakia, erythroplakia. I don't think so today. Can we learn more about it in future? Yes. If you look at the current publications on leukoplakia,
there is a staging system for leukoplakia in itself, and I think that might have been covered in one of the previous lectures. Because, as Professor Shah said, the entire premise is that this has to be a malignancy. But for leukoplakia, there is a staging system based upon size.
Okay, great. So Abhishek, how do you, look for the verrucous carcinoma neck? Are you going to address, just as somebody has asked me the question probably regarding the management aspect?
Okay. Yeah. So verrucous carcinoma does not, not very uncommonly it comes as a pathology in your biopsy reports. But we reviewed verrucous carcinomas in our institute over the last year, and most of these on resection turned out to be well differentiated squamous cell carcinomas. So for me, the philosophy regarding management of the neck is no different in verrucous carcinoma as compared to squamous cell carcinoma. I would do the same philosophy of treatment.
Okay. So is there any inclusion of soft tissue deposits in this staging system?
No, there is no inclusion of soft tissue deposits in the staging system, but they would, but most pathologists would label them as N3B, because these are deposits of malignant deposits outside the node. So most would label them as N3B.
Okay.
Shakti, if you look at the staging system, especially the most important prognostic factors that we have learned now, which Abhishek already mentioned, is the extranodal extension. A positive margin is not a staging system, but anytime there is a positive margin, these patients are not going to do well. There is one other important factor. Again, these are all variety of prognostic factors. When you resect the tongue cancer, what is the age of the tumor? EDGE, age of the tumor. Is it uniform? Is it infiltrative? And this has been described by Margie Brandwein when she was at Mount Sinai and now at Columbia, that this is different. The front of the tumor, is it well-defined? Is it irregular? Is it infiltrative? And there is one last classification where it is called as tumor emboli or tumor islands. So you resect a tumor with good margin, and there are tumor islands left behind what we see. And those are the patients definitely likely to recur.
Okay, so adding on to this ENE positivity, there's a question regarding adding clinical ENE. Does it alter treatment plan in oral cancer as compared to the older staging system?
Definitely. If there is a clinical extranodal extension, means the nodal size is large, it is infiltrating into the surrounding areas. Those are the patients who will be most benefited with multimodality. Now, if you look at the 2004 publications, there were two almost identical publications from different parts of the world, one from EORTC and the other one from United States, RTOG, which showed that the two important prognostic factors in consideration of postoperative adjuvant therapy were extranodal extension and positive margins. And that's where we started, or we introduced chemoradiation, postoperative chemoradiation. Now, if you look at the data, and this has been published again and again, very critically, the benefit is marginal when we add chemotherapy. But when you add chemotherapy, you need to be very sure that the patient is not going to get side effects and ill effects of chemotherapy. So there is a lot of interest in extranodal extension. If there is a clinically apparent extranodal extension, the multimodality is a rule of game, and the risk of recurrence is very high. You mentioned about the soft tissue involvement. That's gross extranodal disease. Those are the patients who are more likely to recur in future.
Okay, so thank you, sir. One more question for Dr. Abhishek. How do you clinically evaluate the depth of invasion or depth of infiltration?
Okay, so I said in my talk, clinically it's difficult. Oral ulcers are tender, and patients usually will not allow a very detailed examination. But the method described is pinch test. You have to hold the tumor, the maximum dimension, the depth of it within your thumb and index finger, and try to assess clinically. But mind you that the clinical staging also additionally includes imaging, and that should be the predominant part of your clinical T-staging vis-a-vis depth of infiltration. It is difficult to do it on clinical examination alone. You can at best make a guesstimate.
Okay, great.
The depth of invasion clinically is $1 million question. We don't use million now. You know, million is simple. You know, everybody has $1 million. We call it $1 billion question. Be like boy, $1 billion question. It's difficult. But the traditional teaching is you feel the tumor, you get a sense of depth of invasion. If it is deeply infiltrating, you know that this is a bad tumor. Again, clinically, it is almost impossible to tell, is it 5 millimeter or is it 6 millimeter? But you can differentiate, is it a good cancer or is it a bad cancer? Is it deeply invasive or not? That's all you can distinguish. Now, some people have used intraoral ultrasound to evaluate the depth of invasion. But again, you have to realize these are small number of cases from institutions who have deep interest in oral ultrasound, and they are not going to be reduplicated around the world.
Okay, yeah. So
you can also use clinical examination criteria such as ankyloglossia, whether your skin is indurated. These are all rough clinical. But once again, as I said, clinical examination can only be a rough estimate.
Okay. So suppose if you have a depth of around 1 centimeter, yeah, more than 1 centimeter, like how now we'll stage this as a stage 3, right? So how do you address the neck? Is it right to address the contralateral neck if it is stage 3 or the depth is more than 1 centimeter?
Abhishek, you want to take or you want me to take it?
Yeah, so Professor Shah, I think I'll go first and then you can add on to anything I've left out. Whether to address the contralateral neck depends upon two things. Whether your tumor is extending across the midline and therefore would have the propensity to spread to the contralateral nodal basins. And secondly, do you have a heavy nodal burden in the ipsilateral neck? So if your disease is across the midline, that is when you address the contralateral neck, at least prophylactically, a selective neck dissection. The second criteria which I use for tongues especially is a heavy nodal burden, and that is when I occasionally address the contralateral nodal basin as well. For the second criteria, there is no good evidence. For the first criteria, there are several retrospective studies. We have an Indian study coming from Tata Memorial Hospital, which was done by Bikramjeet Singh and Professor Pankaj Chaturvedi.
Sir.
Very well said. I think the answers were very well composed. The one other point I want to add is the contralateral side is invariably N0. N0 on clinical exam, N0 on imaging studies, and I'm going to add one more, N0 as a clinical suspicion. As you said, the tumor is not crossing the midline. It's not very close to the midline. The ipsilateral side is either N0 or minimal disease. The risk of having contralateral disease is small. I won't add it. Today, at least, when we radiate these patients, we radiate both sides. So we expect that the contralateral N0 or N disease
rightly said.
will best control with
Abhishek, is that
post-radiation therapy.
If there is ankyloglacia, how is that? Ankyloglacia.
This is called Shah's classification. That's a newer classification. You go to the VA hospital, Veterans Administration, everybody comes with stage 4. So we have to now define stage 16, 17.
So ankyloglacia, at least until AJCC 8 came, would have been T4A because it would have implied the extrinsic muscles, probably T3. But I would note that I would make it a point to note in my clinical notes that there is ankyloglacia with a fixed tongue.
Ankyloglacia is a bad sign. The patients who present initially with ankyloglacia, that means they have neglected the disease for years and years. What happens is when the tumor goes in the depths of the tongue, it goes to the root of the tongue, which is very close to the hyoid bone or involving the hyoid bone. And unless you do a satisfactory operation of encompassing all these areas, the tumor recurrence is almost a given. These patients recur with a high incidence, and once they recur, the chances of salvaging them is almost single digit or less.
Right, sir. So last few questions, probably another 1 or 2 questions. There's an interesting question. Skin fixation, unknown primary. How do you stage and how do proceed with neck to address?
Is that a hypothetical scenario?
It's a very hypothetical scenario which is being given as a question.
Okay, so unknown primary, if there is no primary evident on a clinical examination and on a fiber optic scopic examination of the head and neck, I would probably ask for a PET CT scan. As regards to the end staging, it would be N3B obviously because there is skin involvement. If the PET CT fails to show any uptake at any putative site in the head and neck, we would call it an unknown primary. I haven't seen an unknown primary with a 1A nodal metastasis with skin adherence as of now.
I think that's probably the summary. The finding level 1 nodes with unknown primary is quite rare. If you do see something like that, think you may be dealing with a primary tumor in the submandibular salivary gland or in the sublingual salivary gland or minor salivary glands, which mimic many times as a nodal disease. So make sure that your pathologist does appropriate immunohistochemistry to rule out one over the other.
Correct. So last question for Dr. Shah, sir. Like, as you said, for stage 3, stage 4, we are going to give multi-modal modality of therapy. So in case of tongue with a depth of 4 to 6 centimeters, 4 to 6 millimeter, are you going to give any adjuvant treatment based on that?
You know, there is a lot of debate about neoadjuvant therapy. And, you know, you mentioned about ankyloglacia. That may be a classical example to use neoadjuvant therapy to see the impact. The interest in neoadjuvant therapy in the United States has gone down because the results with concurrent chemoradiation have shown equal or better results. Now, when do we use neoadjuvant therapy? When the surgeon is very uncomfortable to do a big operation. He knows that I'm going to operate, but the tumor is going to recur in the recovery room. He says, okay, let me try something else. And most of the time what happens is when you want to send the patient for chemorad, the 2 services, etc., takes long time to get scheduled or even for surgery. So you find an alternate way. Okay, so I'm not going to do anything for 1 month because my plastic surgeon is not available to do microvascular reconstruction. I'll use neoadjuvant chemotherapy. And there are a lot of interest about the TPF has shown excellent results, no doubt about that. The one good thing about the neoadjuvant chemotherapy is it is a good yardstick to see how the patient is going to do in future. If by chemotherapy the tumor has disappeared or there is more than 50% response, then you know that overall this patient is going to do better. And there will be more interest in concurrent chemoradiation with better results.
Thank you, sir. It was a fantastic session. I think we have crossed our time limit. It's already 5:05. So I will hand over to Shalini, and I thank Vishal Rao sir, HCG Academic team, Shalini, for giving us this opportunity to moderate the session. Thank you, Ashok sir. Thank you, Dr. Abhishek.
Thank you,
Thank you so
Shakti.
very much.
You did a great job.
Thank you.
Shalini, you are muted, I suppose.
Sorry about that. Thank you everybody for joining in today. We've had such a fantastic session today. I must thank Dr. Shaha sir to join us and give us his insights. It was exactly how we expected it to be. Dr. Abhishek Vaidya sir, it was a fantastic presentation, and thank you so much for enlightening all of us. Dr. Shakti sir, you did a fantastic job. Thank you so much for joining in. I think
Thank you.
I wouldn't be doing justice if I didn't mention the team that works behind this. Dr. Anand, Subhash, Dr. Bhargav, Dr. Ritvi, and all our fellows. I think all of them make this happen. Thank you so much everybody for coming forward. I hope to see all of you all soon in the forthcoming sessions. The next session is going to be on radiological pointers for oral cavity cancers by Dr. Arya from TMH. So hope to see you there also. Thank you so much for joining in. Thank you.
Thank you, Shalini and Vishal. You guys did a great job. Shalini, keep the smile.
Thank you.